The following podcast is part of a certified educational activity titled The Changing Future for Patients with Rett Syndrome and Their Families, Early Diagnosis and New and Emerging Therapies to Reduce the Burdens of Disease. Access the entire activity and complete the post-test at peerview.com/VWR860. Downloadable slides and practice aids are also available.
Hello, everyone, and today we're going to be having panelists, myself, Jeffrey Newell, and Alan Percy. Hi, my name is Jeff Newell. I'm the director of the Vanderbilt Kennedy Center and a professor of pediatrics, pharmacology, and special education at the Vanderbilt University Medical Center. And I'm going to start off talking about the issues related to identification of Rett syndrome and being able to do it earlier and differentiate from other more common neurodevelopmental disorders. The goals overall for this program are to identify people with Rett syndrome earlier, to provide age-appropriate care for patients with Rett syndrome as recommended by consensus guidelines, to evaluate the evidence surrounding new and emerging treatments for Rett syndrome. So Rett syndrome is a rare, debilitating, and progressive genetic disorder. It's a severe neurodevelopmental disorder. It primarily occurs in girls and women, and it's actually the second most common cause of genetically identified severe intellectual disability in girls and women, but it may also occur in boys. Prevalence is about 1 in 10,000 to 1 in 15,000 live female births. And there's additional clinical features that are present in affected individuals. Most people with Rett syndrome have loss-of-function mutations in an X-linked gene called methyl-CpG binding protein 2, or MECP2. Most of these mutations are spontaneous and not heritable, meaning neither the mother or the father has a mutation. And there are hundreds of disease-causing mutations in MECP2 that cause loss of function, but there are 8 common recurrent point mutations that account for about 65% of the disease burden in Rett syndrome. So an important thing is trying to make a timely diagnosis, and part of it is to provide the ability to counsel the family and the caregivers about the prognosis and potential comorbidities, initiating therapies such as physical, occupational, and speech therapy, which we think might be beneficial if they start earlier, and early aggressive treatment for some of the associated gastrointestinal and nutritional issues can help prevent malnutrition and growth failure. So the age of the onset of regression generally occurs about 2 years old. And now that there are targeted therapies available and there are more therapies being developed, earlier use of these might provide more benefit. So what is Rett syndrome? It has a characteristic disease pattern and a set of clinical criteria where there is a normal birth and delivery, typically uncomplicated, and then apparently normal neurologic development and physical development for the 6 months of life. But then there is a period of developmental delay from 6 to 18 months. And then there's a regression. So it's a characteristic pattern with normal development, but then a regression of acquired milestones, acquired skills in spoken language, purposeful hand skills, and an impaired ability to walk or inability to walk, and development of characteristic hand stereotypies. So you have this characteristic disease pattern, and then these 4 major criteria: regression of hand skills, spoken language, difficulty walking, and repetitive hand movements. That's for the diagnosis of classic or typical Rett. There is an atypical Rett class diagnosis. It also has the same disease pattern with a period of regression and stabilization, but it meets 2 of the 4 major criteria plus 5 of 11 supportive criteria. And this is the list of supportive criteria. These are features that are found very commonly in classic Rett, like abnormal breathing, hyperventilation, small cold feet, intense eye communication using eye pointing. Now, there is a delay in the diagnosis of Rett syndrome in work done with a large national history study. The median age of diagnosis was 2.7 years for people with typical Rett. Now, these earlier signs and symptoms may be subtle and not quite appreciated by clinicians. And trying to increase the awareness of clinical features and then subsequent use of genetic testing is now resulting in earlier identification and diagnosis of Rett syndrome than in previous. Most often, the diagnosis is made by a neurologist, developmental pediatrician, or geneticist, and it's very infrequent that in this case study that it was made by a pediatrician or another primary care provider. So there needs to be a level of suspicion for Rett syndrome when there might be subtle signs of delay and definitely regression, especially in girls between 6 months and 3 years, especially the characteristic features of the loss of hand skills and the repetitive hand movements. Now, the other is the deceleration in the rate of head growth, which is a common feature in Rett syndrome, and I'll come back to that, and that's an important aspect to potentially diagnose earlier. Some of the differential diagnoses that could be included are things like autism, Angelman syndrome. Sometimes people consider cerebral palsy, although there isn't typically any evidence of perinatal trauma, and there's no evidence of any imaging findings from an MRI. And then other things like Batten's or neuronal lipofuscinosis, and then other just nonspecific developmental delay. There's a clinical overlap with other disorders with a lot of nonspecific features, such as scoliosis, reflux, fractures, self-abusive behaviors that can maybe make it confusing about the diagnosis. Now, while I've mentioned the deceleration in the rate of head growth as common, not all individuals become microcephalic. And so it can be a common misperception that because the person, even if they had a deceleration in head growth that was noted, but still have a normal head circumference, that may delay the diagnosis. And so it's very important to be considering the timing of developmental milestones because they may be delayed, but not beyond a normative range. So it may not be walking at a year, and the pediatrician may say, well, but maybe they might not walk till 18 months. And then, of course, the regression in hand skills, spoken language are a little more dramatic. And then the physical findings may be including impaired growth, decelerated head growth, to microcephaly in the hand stereotypies. This meeting the criteria for Rett syndrome, would be typically followed up by a genetic analysis to look for pathogenic variants in MECP2, which is found in 95% of people with classic or typical Rett and 75 people with atypical Rett. However, it does not itself make the diagnosis of Rett syndrome. There are people who have MECP2 mutations who do not meet the criteria for Rett syndrome. And there are people who have all clinical features of Rett syndrome who do not have a defined mutation in MECP2. So you can't have it being just exactly equivalent for the genetic diagnosis. There's a typical disease pattern where the stage 1, I said this early onset and developmental delay. Stage 2 is regression, loss of these skills and development of hand stereotypies. But then a stabilization, which is stage 3, the pseudostationary or plateau stage, where there's no further regression. You don't really see much improvement in the skills. And then a number of other comorbid features, such as seizures and breathing problems, might become evident in that point. And then finally, stage 4 is called light motor deterioration. This is characterized by increased tone, hypertonia, and rigidity, and more difficulty moving. It might have Parkinsonian features and progression of the scoliosis to the point that it might need to be intervened. And this occurs more in the teen years to young adulthood. Now, there are boys who have MECP2 mutations and ones that actually meet criteria for Rett syndrome. So this was originally identified in rare cases of familial cases of Rett syndrome, where the mother is an asymptomatic carrier, and they had very severely affected male siblings. And this led to the initial understanding that you'd have this severe neonatal encephalopathy associated in boys with these MECP2 mutations, where they're severely affected from birth and really require maximal medical support, including tracheostomies and external ventilation to survive. However, there's been boys who meet all the clinical criteria for Rett and look exactly like any other girl with Rett syndrome. Some of these boys also have Klinefelter syndrome, where they have an XXY. They have two X's and a Y, but are phenotypically male, and they have a MECP2 mutation. Or they have a somatic mutation in MECP2 that occurred during embryogenesis, so they are a mosaic for the MECP2 mutation in their body. Now, we've been recognizing many more boys with MECP2 mutations than we previously knew, and the phenotypic spectrum is much broader. In general, they are more severely affected than boys, but they can meet the criteria for Rett syndrome with loss of function, with loss of skills. We've been terming some of these boys male Rett encephalopathy. But the issue is that the common wisdom that the notion that Rett syndrome could only occur in females can lead to diagnostic delays and problems in boys who have MECP2 mutations and features of Rett syndrome. So let's talk about a case of Maddie in her first 6 months. She had relatively normal development. Her family thought she was a bit floppy and maybe overly good, generally quiet and falling asleep easily. At 1 year visit to the pediatrician, the family raised concerns that Maddie, while she had sat and crawled, she wasn't pulling to stand or walking as her brother had done at that time. The pediatrician had reassured them that the skill development varies between children, that it's still time and should be fine. Her head circumference, which was at 90% at birth, is now only at the 50th percentile. At 20 months, there was an urgent visit to the pediatrician because in the past month, Maddie stopped using her 5 acquired words and was now only babbling. She also had no longer been self-feeding with the pincer grasp, which she had been doing earlier. And then she started exhibiting this hand-wringing. She was having more difficulty initiating steps, and she seemed to be withdrawn and having decreased social interactions. Okay, I think I'm going to shift over to my colleague, Alan Percy, and he's going to talk a little bit about clinical care.
Good morning. I'm Alan Percy. I'm a child neurologist at the University of Alabama at Birmingham. I'm happy to be here. So we're going to talk about some consensus criteria that were elaborated in 2020 by Carrie Fu and other associated with this project. It involved a large literature review of Rett syndrome features, consensus comments with a modified Delphi approach from external review and public comment. And we had further input from the Rett centers that were developed around the country at this time, as well as some parent advocacy group input. Now, these two quotes are important to understand. The overall multi-system issues of Rett require primary care providers and other healthcare professionals to manage complex medical comorbidities within the context of whole individual and the family. Given the median life expectancy of girls with Rett syndrome or women with Rett syndrome, guidance is provided to health professionals to achieve current best possible outcomes for these special needs individuals. Now, there are multi-system involvement in girls with or women with Rett syndrome, as Jeff has mentioned. And these include really a laundry list of problems which cover most of our biologic systems, including seizures, GI problems, chewing, eating, swallowing, constipation, growth failure, poor muscle tone with low tone initially, which eventually becomes normal and everybody is happy, and then becomes increased or with greater rigidity. Scoliosis is a significant problem, as well as sleep problems and the breathing irregularities that were mentioned. When we consider approaches to girls at various ages, it's important to recognize that some of these features vary. So during the first 5 years of life, you may not see features of scoliosis. You may not see significant features with tone issues, but you will see problems with feeding, perhaps inability to swallow appropriately, so some food goes into the trachea, and therefore a G-tube is required. About a third of the girls with Rett syndrome do require alternative feeding methods with a G-tube. Seizures may begin to appear at the end of this period, but are generally not that common. But issues with sleep can be significant. Later on, from 5 years up through the prepubescent period, issues with seizures, the irregular breathing, so hyperventilation or breath holding, principally during wakefulness, and this can be so significant that it interferes with all activities, including eating, educational activities, or interacting with their peers or their family. Scoliosis begins to be a problem as well. At this point in time, a further assessment of weight and height increase should be characterized, and should be known that girls and women with Rett syndrome are typically quite small, with their weight rarely exceeding 100 pounds and their length rarely reaching 5 feet. After puberty, and puberty really occurs about the same time as in the normal female population, although there is a portion of the population that has early onset of puberty, and the onset of menses is a little bit later than in the general population, but is essentially normal. In adulthood, particularly after age 21, when school ends, problems emerge because there is often no place for the child to go during the daytime, and therefore one or even both of the parents may have to give up work or limit their working activities to manage the care of the child. So these assessments are recommended in this guideline and should be taken to heart. There are also psychosocial issues that involve the families and the girls with Rett syndrome. The financial burden, the emotional burden, and the physical effects of Rett syndrome are substantial, and this can affect the siblings as well as the parents. As these girls age, the parents age, so they have greater difficulties moving around. The girl who may be total care has to be moved from chair to wheelchair, chair to the toilet, chair to bed. And if you lift even 80 pounds several times a day, that takes a toll on you. Some of these girls are actually quite capable of getting around, ambulate reasonably well, can get to the stove, get to the water, can even get out of the house. So care must be taken to protect the environment for those girls who are better able to function. Their educational enrichment programs are available, government support and other agency support is available, and the family needs to take advantage of home health as well as respite care, because it is important to consider the health of the families as well. And in addition, as the girls reach 18, they become adults, and the parents no longer have control. So parents need to obtain guardianship and conservatorship prior to this period. The consensus guidelines did provide input from the Rett advocacy organizations, but the question is, do families and clinicians prioritize the same goals of care? And do the clinical trial endpoints reflect these opinions? So the current FDA guidance advocates that the affected individual's voice, or in this case, the caregiver's voice, should be heard when discussing outcome measures. Caregivers of participants in our natural history study were asked to identify their top 3 concerns. These were from a 21 list of predefined concerns, as well as the option to write in another concern as free text. The top concern was communication, followed by seizures, lack of hand use, abnormal walking, and constipation. These concerns obviously varied by the patient problems, as well as their mutation and their clinical severity, which they displayed. Let's meet Zoe. Zoe's a 19-month-old girl with a newly diagnosed Rett syndrome. She had loss of hand use. Her pincer grasp stopped, and she was only able to grasp with her palm. She had loss of acquired words of mama and dada, and now was only babbling. She'd lost her previous ability to stand, and she had finger rubbing movements when not otherwise involved. And genetic testing found a pathogenic mutation in MECP2, which is one of the more significant mutations in terms of clinical severity. The family was concerned about Zoe's prognosis and looking for guidance on potential clinical problems and medical management. So it would be appropriate at this time to discuss the potential problems that the family was looking at during the next few years, as well as longer-term issues. However, it probably is wise not to overemphasize the significant features which may occur in the future but might not occur. But it is very important to consider growth, nutrition, access to early intervention, and other issues in the early infancy and childhood period. In terms of atypical or typical Rett syndrome, it's interesting. There are individuals with atypical Rett syndrome who are actually more severe or significantly involved than those with Rett syndrome, and other individuals who are less significantly involved. So one has to look at these girls quite carefully to decide what issues are more likely to occur and need attention.
I'm going to start talking about the targeting at MECP2 treatment, the advances in the care and treatment options that have been developed and are being developed. So again, the road towards the development of therapies for Rett syndrome really, as mentioned before, the majority of people with Rett syndrome have mutations in MECP2. MECP2 is a gene that encodes a protein, methyl CpG binding protein 2, or MECP2, that binds DNA, methylated DNA, and recognizes these epigenetic marks, and it regulates the expression of the other genes. It regulates a large number of other genes. The largest level of expression is within neurons, even though it's expressed in pretty much all the tissues in the body. And it seems to be very important for overall neuronal function and the establishment and maintenance of synaptic connections. There are animal models that have been made, and they show a variety of phenotypic abnormalities that are very similar to those seen in people with Rett syndrome. And importantly, work done in 2007 found that when you restore MECP2 function in symptomatic animals, that by genetically turning the gene back on in an engineering feat, this would reverse the symptoms. So the animals could be clearly sick, and you could turn the gene back on, and then they would get better. They got better. And so this really demonstrated potential for meaningful therapy development and real hope. There is an issue that there's a small therapeutic window in terms of adding MECP2 back, because too much MECP2 activity can cause problems. In fact, there's a neurodevelopmental disorder called MECP2 duplication syndrome, where they have an extra copy. So both gain and loss of function of MECP2 can cause neurodevelopmental disorders that are both severe. So you have to be in the right range of how much MECP2 you put back. Here's a little video about aspects of loss of function of MECP2.
Functional MECP2 depletion is hypothesized to be a major contributor to the CNS manifestations in Rett syndrome. MECP2 mutations lead to the dysregulation of several molecular processes and mechanisms, including brain-derived neurotrophic factor, or BDNF, microRNA, and glutamatergic pathways, leading to impaired neuron growth. BDNF is a signaling protein and member of the neurotrophin family of growth factors that influences survival, development, and improved function of neurons. BDNF stimulates the differentiation of progenitor cells to form neurons, supports the survival of existing neurons, and encourages growth and strengthening of new neurons through axonal and dendritic sprouting, leading to increased connections with other neurons. It also strengthens the synapse through increasing numbers of receptors, resulting in improved cognitive function. The lack of BDNF results in the weakening of synaptic strength, making neurons more vulnerable to stressors and atrophy. It leads to a disruption of signaling, decreasing synaptic connections required for efficiency in memory and learning. MicroRNAs are involved in glial and neural cell type determination, migration of newly formed neurons, neuronal cell type determination, neuronal polarization, axonal formation, and dendrite branching. Interruption of microRNA pathways in the CNS may result in gross abnormalities, for example, ataxia and gait abnormalities associated with cerebellar impact. The exact interplay of molecular interactions is complex and remains unclear. MECP2 deficiency disrupts processes involving glutamatergic synaptic responses and astrocyte, glial cell, microglia, and oligodendrocyte functions. Dysfunctional glutamate signaling can result in neurotoxicity and negatively alter brain function.
So, recent work has led to the first FDA-approved treatment for Rett syndrome. This was approved in 2023 in March for adults and children who have Rett syndrome who are over 2 years old. It originally had received priority review, orphan drug designation, fast track drug designation with the FDA. The dose is weight-based. It's administered orally or via G-tube twice a day. So what is trofinetide? So trofinetide is a synthetic analog of a tripeptide that's derived from the amino terminus of insulin-like growth factor 1. The tripeptide is glycine proline glutamate, or glypromate. This is a naturally occurring cleavage product of IGF-1. It has a variety of activities that are independent of the IGF-1 receptor. It seems to help improve neuronal and glial function. And the treatment with glypromate in animal models of Rett syndrome improved features. So this synthetic analog trofinetide, it is basically identical to the glypromate. It has a methyl group, so it improves the drug qualities, meaning it has a longer half-life. It can be taken orally. And the exact mechanism of glypromate and trofinetide is not known, but it may be related to reducing neuroinflammation, helping improve overall synaptic function and dendrite morphology. There were 2 phase 2 trials that were conducted with trofinetide, one in adults and one in children in Rett syndrome, and both of them showed that trofinetide was safe and tolerated, and they both had evidence of efficacy on clinician and caregiver rating scales. This supported the initiation of a phase 3 trial of trofinetide, and that was called the Lavender trial. It was a 12-week phase 3 study, ultimately in having 187 people with Rett syndrome between 5 and 20 years old, randomized on a 1-to-1 basis to either trofinetide or placebo. It had co-primary endpoints, which were changed from baseline in 12 weeks on a caregiver scale called the Rett Syndrome Behavior Questionnaire. This is a 45-item caregiver scale. It's called the Behavior Questionnaire, but actually covers a wide domain of features that are found in people with Rett syndrome, so it's not only behavioral abnormalities. And then the clinician caregiver impression of improvement. global impression, the CGI-I, using, this is a 7-point scale, ranks improvement or worsening, and there's Rett syndrome specific anchors and specific training on using it to try to have inter-rater reliability. Here are the outcomes for the lavender in terms of the primary endpoint of the caregiver scale, the RSBQ. And this is on the left-hand side showing progression over time, and this is showing change. This is decrease, and decreased scores is better. Higher scores on the RSBQ are worse. And you see at 2 weeks, both the placebo, which is in orange, and the trofinetide group showed a drop, which is an improvement. But over the rest of the time, to 12 weeks, the people in the placebo group, the families, went back to baseline, and the trofinetide group stayed low. So that initial 2-week decreases seems like a placebo effect, which was very similar to what was seen in the phase 2 pediatric trial that actually had a single blind run-in period, and you had a marked placebo effect on the caregiver scale. So at week 12, you had a difference favoring trofinetide compared to placebo. On the the right-hand side of it, it shows the subscales of the RSBQ with directionality to the left, meaning favoring trofinetide, so you can have a number of subscales of these different features. And you see that all of them trended to move towards improvement with being on trofinetide. And it wasn't just one or two things that drove the overall improvement. It was kind of distributed across the RSBQ. This is the Clinical Global Impression of Improvement Scale, the CGI-I. And again, you see that there's a split in favoring trofinetide, which again is decreased scores at 12 weeks. And then these are the p-values. Doesn't have the effect size. Both of these had effect sizes that were in a moderate range, with Cohen's about 0.4 to 0.5. Now, let's talk about the treatment emergent adverse events. The most common was diarrhea and vomiting. And you see that in the trofinetide group, about 80% of the people had diarrhea compared to 20% in the placebo, which is still rather high. It's unusual for 20% of people with Rett syndrome to have diarrhea. And then the next was vomiting, which was about 27% in trofinetide compared to about 10% in placebo. Most of these were mild or moderate, and the diarrhea was the most common adverse event leading to withdrawal from the trial. About 13% of the people withdrew because of diarrhea. Now, when people go off of trofinetide, the diarrhea usually resolves. And during the course of the study, a management plan was developed and implemented, and that's been published about how to approach management of diarrhea when on trofinetide. About 75% of the people who received trofinetide during the double-blind phase completed the trial. There is the concern for functional unblinding due to the high rates of diarrhea. But when a sub-analysis was done looking at the people who had diarrhea, who didn't, and how people were ranked, actually the people who had diarrhea, both the caregiver and the clinician gave not as favorable scores as the people who did not have diarrhea for their ranking. So if anything, it actually might have been biasing people to give worse scores than better. So it doesn't seem to really affect the unblinding. There have been three other studies that were conducted with trofinetide that were open label studies. One was called the Daffodil in people who are 2 to 5 years old, which is primarily focused on pharmacokinetics and safety. That's been completed, and then open label extensions called Lilac and Lilac 2 for the people who were part of the Lavender trial that have continued on. But all of these now have ended and are being analyzed. I'm going to shift gears now and put it back to Alan about other treatments for Rett syndrome being developed.
So there are other treatments for Rett syndrome, which are in the study phase. None of them yet has reached level of either a phase 3 trial or FDA approval. The first is blarcamesine, which is a tongue twister. It's a product of Anavex, which is Anavex 2-73. Blarcamesine is a sigma-1 agonist and muscarinic receptor modulator. In mice, it showed, similarly to trofinetide, that it improved cellular homeostasis and synaptic plasticity. It did increase the release of BDNF and resulted in a variety of improvements in motor, sensory, and autonomic features. The top-line results from a phase 3 trial in women 18 to 45 were reported about a year and a half ago. 72% of the treatment arm versus 39% of the placebo arm showed a significant improvement for the primary endpoint, which was the caregiver-reported RSBQ that Jeff has already discussed. Meaningful improvements were also noted in 2 other clinical outcome measures, the CGI as was used in the trofinetide trial, as well as the ADAM score, which is a behavioral score. A multi-center, double-blind, placebo-controlled trial was then completed in June of this year with 92 patients aged 5 to 17. Dose escalation, safety, tolerability, and efficacy were the outcomes looked at, and the co-primary endpoints were the same as in the trofinetide, the RSBQ and the CGI scores. The top-line data have not yet been released, but we do expect them shortly. As with trofinetide, blarcamesine has the same fast-track designation, rare pediatric disease designation, and orphan drug designation from the Food and Drug Administration. Another treatment which has been investigated recently is that of ketamine. Ketamine is a non-competitive N-methyl-D aspartate or glutamate receptor, so-called NMDAR receptor antagonist. This was studied in a phase 2 placebo-controlled crossover trial assessing safety, tolerability, and efficacy in girls who were 6 to 12 years of age. The results are currently being analyzed and are expected to support a phase 3 trial. Ketamine has also been offered orphan drug status by the FDA. And excitingly for many individuals, 2 gene therapy programs are available. One is by Taysha Gene Therapies. The other is by Neurogene. These are both American companies using a similar but not identical recombinant, non-replicating, self-complementary AAV9 vector-encoded MECP2 gene, which has some regulatory elements to prevent some overexpression that Jeff mentioned could be a problem. The administration of these 2 compounds, in these 2 companies, is different. In the Taysha trial, it's intrathecally, and in the Neurogene trial, it's intracerebroventricularly. Also, the Taysha trial was initiated, or has been initiated in Canada, and it is in adults who are those greater than 18 years of age. And the Neurogene trial, which I think has just been initiated, involves children of 4 to 10, and it is in this country. So let's meet Alicia. Alicia is a 5-year-old girl who was diagnosed at 3 years of age with typical Rett syndrome. She vocalizes with vowel sounds, occasionally reaches for objects but cannot grasp. She has constant hand clapping stereotypies and frequently holds her breath. She has 2 to 4 paroxysmal events per week with freezing and limb stiffening associated with breath holding. She has been on oxcarbazepine for treatment for previously identified or diagnosed seizures. but has had no change in response to these paroxysmal events with ongoing treatment. What's the next step in management? Should we start another anti-seizure medication? Perform a prolonged video EEG to evaluate whether the paroxysmal events are seizures? Recommend epilepsy surgery, or recommend a ketogenic diet? Our experience has told us that we should perform the video EEG because many of these events do not have an epileptic signature and are regarded in many cases as Rett spells. I understand that's not a very attractive or accurate term, but it differentiates these issues from actual clinical seizures. Coming back to Alicia, what would be the indications for a novel or emerging therapies in Rett syndrome as they apply? Well, currently, any girl, woman, even boys who meet criteria for Rett syndrome are considered candidates for treatment with trofinetide. This is, as Jeff mentioned, a weight-based twice a day exposure to this medication. And we have typically started lower than the recommended top dose and gradually increased that on a weekly basis up to the top dose. We understand the potential for diarrhea or vomiting, and we have instituted programs for managing this. The anticipated benefits and risks or therapy modifications need to be considered. Most of the improvements that are seen in girls with Rett syndrome are improved interaction, communication, in some cases better walking, in some cases more ability to answer questions through a Tobii device or a video tablet. So we do recognize that it's important to look at benefits and risks and discuss these openly with the family. The strategies to incorporate the use of new treatments into clinical practice, including initiating treatment with current and newly diagnosed patients, I think this has already been discussed. We are very excited about the availability of treatment, and we look forward to other treatments coming online in the coming years. So what are the takeaway messages? As mentioned, Rett syndrome is a rare, debilitating condition that varies in its presentation and primarily affects girls. The 2020 consensus guidelines provide recommendations for management by primary care providers and specialists. And I want to emphasize the primary care provider because the number of specialists may vary from time to time, and over time, somebody has to be a quarterback, and the primary care provider should be this person. The focus should be on meeting both the patient and the family needs along a spectrum from early age through adulthood. The Rett treatment paradigm, which is aimed at symptomatic management, changed dramatically this year with the approval of trofinetide aimed at the Rett pathophysiology. And we anticipate additional treatments as a developmental pipeline moves forward. Jeff, do you have any comments?
No, I think that's great. And the only thing I wanted to add, though, is that in terms of the gene therapy, the Taysha trial initiated in adults in Canada, but they recently received FDA approval and IND approval to do a trial here in the U.S. in children. And I noticed that about 20% of the people gave the answer to phase 3. It was phase 3 trials. Neither of these are phase 3 trials. They're phase 1 trials for gene therapy. They're first in human and very small numbers initially to look at safety. So just that was my main comment about that. But great. Do we have another? Okay, so it's question and answer time. I was going to kick off, just because we have a number of, there's some questions that have already come through. And so some of them, I'm going to combine a couple of them. There's a timeline for implementing treatment, when it's too late, how frequent is early diagnosis essential for therapy treatment, and then trial medication eligibility. So with regards to trofinetide is approved for people over 2 years old with a diagnosis of Rett syndrome. The FDA label does not say anything about typical or atypical. It doesn't say anything about requirement for a MECP2 mutation. It doesn't say anything about sex, male, female. Now, our experience of actually getting this approved by third-party payers, oftentimes they will ask for a number of things that are not necessarily on the label, like MECP2 mutation. Now, in terms of the when is treatment too late? So I'll start with a trofinetide experience. So the first phase 2 trial was in adults who was 16 to 45 years old, and there was evidence of improvement in that age range. So there is no, there does seem to be opportunities even in adults, even though the phase 3 trial was in 5 to 20-year-old. But in terms of other therapies too, such as gene therapy and stuff, while I think there's good theoretical reasons to believe that earlier interventions will be more beneficial because of the neurobiology and what we understand about developmental neurobiology, we don't really know that is true yet. And in the animal models, the genetic reversal experiments were done in adult and symptomatic animals. And in the heterozygous female animals, when it was done, they were 40 weeks old, which is a rather old mouse. So it does seem that, at least if going by the mouse models, that there's opportunities for improvement even when in adults and when people are very symptomatic. Now that has to be couched in the terms that, when you have things that result in orthopedic abnormalities like contractures and scoliosis and fixed positional deformities, those are things that in and of itself are not going to be corrected unless there's a surgical correction of things like that. And though that might impact the ability, even if you have the opportunity to, say, walk better, if you have very bad dystonia and contractures, without that being corrected, you probably would not be able to walk. So I just tried to answer those combined together. But now maybe we could open it up to the audience. So we have other people wrote in.
So I had a question. Great job, guys. So are there particular impairments that are more sensitive to treatment than others? It's sort of one part of the question. And if there are, given that in kids they acquire skills with training plus plasticity, have you considered that maybe if you're doing some training in association with the treatment, you would actually have better outcomes?
Yeah, that's a great question. And I'll just repeat it. It was really about the idea of combining therapeutic, like treatment, like occupational learning therapies, et cetera, communication therapy with these new treatments that maybe that have been approved or are being tested, like trofinetide or these other treatments. And of course, I think that is for sure. I mean, to me, I think that's a very it hasn't been formally tested in that way, but I think it's, and I always feel like, if you had a perfect thing that gave you the MECP2 back for gene therapy, I think if you've lost the ability to speak, you probably are going to have to you might have the milieu with the gene back to learn, but you probably are going to have targeted interventions. A lot of people with Rett syndrome get a lot of therapies, but of course it's highly variable how much therapy they get, which is unfortunately heavily tied to access and social economic features, right? About what the intensity is and what the quality is. And so, it'd be, definitely worthwhile considering how you combine these and evaluate them. Alan, do you have anything else to
Yeah,
comment?
we are aware of animal studies that shows that environmental enrichment for the animals leads to better outcomes of the animals. And we actually see that in some of the families where the girls, for one reason or another, do not have access to treatment programs. For example, the use of the Toby device. We have some girls who seem to communicate very effectively with that device. So providing these kinds of enrichment across the board, I think, seems to be an area that needs to be evaluated more carefully than it has been to date. We have no control studies of effects of the Toby device, for example.
Thanks for the nice talk. It's always very exciting to hear about new therapy for the patient with genetic syndrome. So my name is Wei Liang Chen. I'm from Children's National Hospital, Washington, D.C. I have a few questions, but I try to make them simple. So first of all, looks like in the trial, the two main concern or the two main the parents' concerns were not really answered by the clinical trial, right? One is the communication, the second one is seizure. Can you guys make some comment on that? I know that Dr. Percy already mentioned some patients have a better communication skill, but I don't feel that this really it was not a primary goal for the clinical trial. And the second, again, the seizure. Can you guys make some comment on that?
Yeah. So okay, basically you're bringing up the top concerns, the weighted top concerns data that was presented, and how it relates to treatment outcomes in the trofinetide trial or other trials, And yeah, the top 5 weighted concerns were communication and things that it aligned with what we might expect because there were skills that were lost, like communication, hand function, walking, but then also these high-level comorbidities, seizures, and constipation. Those are the top 5. And so within the clinical global impression scale of severity and improvement, there are Rett syndrome specific anchors that actually incorporate, a CGI just has one score. It has a score from 1 to 7, depending on its severity or improvement. But in the anchors themselves, they actually incorporate aspects of communication. When you read the anchors, it talks about communication, hand skills, walking, seizures. So those are built in, although it does not specify, you don't see it as just the score, but that's what helps make the determination of the score based on the anchors. Just for context too, the top concerns information, that's data that we've just analyzed and put together and are trying to get published. That's in a preprint. So that's sort of newer than when things were developed for the outcome measures for the trials, right? And even the anchors and stuff. So I think, though, that's an important feature when we think about moving forward with trials and outcome measures and evaluating which would be outcome measures that would be the best to be used for trial or be developed for these kind of things to make sure that they do align with what are the top concerns of the caregivers.
I'd like to throw one thing out, and that is with the availability of a treatment for Rett syndrome, the idea has been mentioned in some circles about newborn screening for girls with Rett syndrome. And as Jeff has indicated, that's a potentially slippery slope because not all girls who have a mutation in MECP2 are destined to develop Rett syndrome. So just basing treatment on a MECP2 diagnosis is dangerous, I think, at this point in time. We need to learn more.
Yeah, and I think it's going to be important for us to develop a better ability to have that positive predictive value. If you have a MECP2 mutation and you're pre-regression, what would be the constellation of things that you could have with high confidence that you are going to go on to develop Rett syndrome? Because I think, as was alluded to, with different therapy development, and I'm sure definitely with gene therapy, as this progresses and if it's safe and seems to show benefit, people are going to want to start intervening earlier and earlier. So we need to have a better sense about absolutely how confident we are that you're going to go on to develop Rett syndrome if you have a MECP2 mutation. Well, anyway, thank you all for coming, and this is a lively conversation.
Thank you.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/VWR860. This activity is supported by an educational grant from Acadia Pharmaceuticals Incorporated.